Hi, everyone, and welcome. Hi, Nada. Thank you for joining me.
Hi, glad to be here again.
Awesome. So, if you guys are joining us live, we are going to be chatting about cruciate disease, cruciate ruptures, and whether to cut or not to cut, and a little bit diving into the ethical dilemma of it, because it really is when we're talking about surgery, we need to consider what is the best for our patients. So, Narda is here from CuraCore. CuraCore is our gold sponsor again this year for the Vet Rehab Summit, which we're very excited about. Before we dive in, Narda, let me just tell everyone about the summit. So our theme this year is ethical dilemmas that are faced by vet rehabbers, or ethical challenges that we face as professionals in the rehabilitation industry. And I know when you initially hear that, it might not sound very exciting, but I am really excited about it because it gives us the opportunity to take a little bit of a deeper dive into some of the issues that challenge us, that grate us, that become a stumbling block for us as professionals. Either in our emotional regulation when we're starting to face burnout. These things that we're going to discuss are really at the root of that issue. And so that really does excite me, and I'm looking forward to that. And this question of whether to operate or not to operate, and at the end of the day, how we take that back to the veterinarians that we're working with, that we're a team with, is a big part of that conversation. So, Nada, will you please introduce yourself and tell us a little bit about your interest in today's subject?
Thank you. Yeah, I'm a veterinarian and an osteopathic physician. As physician first, I still see some human patients, but I've mainly for the past decades been focusing on the veterinary aspect. I taught at Colorado State University for 20 years, began the science-based integrative medicine service back in 96. I hadn't even graduated yet from school, which was in 97. So I've been working with teaching and researching and all that with medical acupuncture. So again, a science-based approach, and then adding in botanical medicine, photomedicine, and massage. As an osteopathic physician, I've always worked with my hands, especially when diagnosing patients, assessing and treating. It's about palpation, so very strong with myofascial palpation, observation of structure and function, and considering the soft tissue, myofascial, just endogenous reasons for any kind of presentation of problems with movement, or even internal medical causes. Because it's all, I mean, it begins somewhere, right? It's when we go back to the origins of pain, of back pain, of neurologic disease, like what happened originally to throw things off, to skew our endogenous capacity to heal, and then trying to reverse that as naturally, as biomechanically favorable, as painlessly as possible, with with various approaches. Now, for the past 6 or 7 years, we've also been teaching rehab. We call it integrative rehabilitation and physical medicine. So with a strong non-surgical bent. It's not that we don't ever need surgery, but when I look at the TPLO, which is a focus of what we're talking about today, I mean, I think it is needlessly intrusive, dare I say, barbaric. And when we understand that there are many ways to protect and heal the stifle, and whether it's the cruciate or anything else, why are we rushing into this very invasive, very risky surgery? So yeah, and I've written a lot about it, and I mean, for a long, long time, I've had animated discussions with surgeons about it. When it comes down to the evidence, I have a lot of questions about what they claim, and what we're hearing people being still taught in school despite the knowledge that we have. And there are just so many ways to not rush into surgery. even if it's a ruptured cruciate, this is not an emergency.
Okay. So guys, if you're joining us live, it's really good to have you with us. We are talking about cruciate ligament disease, cruciate ruptures, and essentially bringing that conversation to should we or should we not be doing surgery, and where does our responsibility lie in that? So if you're joining us live, let us know what your thoughts are, your experiences. If you have any questions, please share them with us. We really are here to have a conversation with you. Okay, so Nada, let's start with diagnosing or identifying cruciate ligament ruptures. How is that currently done? And in your experience, is there a problem with that, that commonly performed diagnostic procedure?
Great question. There are various ways aside from doing that cranial drawer movement, but that is probably the default one and most common. The problem is that it's not fully sensitive or specific, and you could have movement in the stifle that does not mean it's a partial or a complete tear. So some joints are just more lax than others. I have hypermobile joints. And so that, whether we couple in an ultrasound diagnosis or anything else, I mean, it's still, number one, why is our focus just on the cruciate? So when we hear about exams, so, let's sedate the animal so that we can perform a proper draw or whatever, that ignores the role of the neurologic system and the protective function of muscles and ligaments and tendons that surround the joint, because much of rehab is driven, I mean, it starts with the nervous system. It starts with how our nervous system calibrates the amount of tone, stiffness in the muscles. If we're walking down the street and we don't realize that there's a big, rut or a sidewalk step there, we're not prepared to step off that sidewalk and guard ourselves. And I think that the same way, any other mammal would be anticipating, if they saw, that there's terrain that's different here. We're going to see that, adjust our stiffness in the muscles or whatever happens. And that then further adds to the protective sensory motor aspect driven by the neurologic system over joint integrity. So when you block that with an anesthetized animal, and, just solely focus in on the cruciate. Okay, whatever that resting state is, that's that without the nervous system, but that's not a clinically relevant way to go. The next thing is that we have been so cultivated to go down the straight and narrow path to surgery, that we have a paradigm that I hear it all the time in our students. Oh, if there's any damage at all to the cruciate, even if it's, MRI, whatever, any damage at all, well, that's a reason for surgery. Is there a medial buttress? Well, that's a reason for surgery. Is there anything? And then we're, enculturated to believe, oh, well, then the TPLO is the gold standard. There's no evidence that shows that TPLO is preferable to a conservative approach. So, and there are now several studies showing that the cruciate ligament can heal. So instead of the cut to cure idea, which we have to admit, whether somebody is financially motivated or not, the TPLO and treatment of all its complications, and if that surgery center has a rehab facility, this is a big moneymaker. It's billions of dollars per year in the US. And I think that we're not supposed to talk about that. Oh, there's a financial motive. Sure, there's a financial motive. And so we from school on are taught, if there's a pelvic limb lameness, that is a cruciate until proven otherwise, and gold standard is the TPLO. And that's just not true. Did you want to interject?
There are more things to consider. It's not just one way. Okay. You mentioned, so we're talking about the cranial drawer test and that protective mechanism. So to you, would you have a more clinically appropriate image or picture of what was happening in the dog if you were doing that drawer test non-sedated? That's what you're saying, is if we're doing that non-sedated, we get a better idea of the entire stabilizing mechanism of the stifle and how the dog is doing that, handling that, compensating for a potential damage to the cruciate.
Yes, potentially. So then the next problem is how scared the animal is. How much time is the practitioner going to take? So in our rehab course, again, we're very like all about the patient and how to make things the most comfortable for them, and fear-free ideas and myofascial work. So yes, in the ideal state, just getting my dog out here, you would have a relaxed patient and make things comfortable and be doing myofascial. So the whole myofascial exam is another piece that I should get back to. But working with the dog who is relaxed and you're moving slowly. And yeah, I think it's very important to accomplish the drawer test in an awake animal and to move slowly through it. So because I've gotten kind of well known in terms of my anti-TPLO sentiment, I do get calls from across the country. Even I've gotten calls from Europe with the same theme. I brought my animal to the vet. They're insisting that they get a TPLO, and it's immoral if they don't. And plus some of the stuff that I've written is, intervene on behalf of your animal. If the practitioner is hurting your animal, I mean, you can say stop. And so I remember it was from Alabama, a distraught man, and he said, I told the vet to stop because I've seen it with my own patients and even with a non-vet. So a physical therapist, we can all be guilty of anything, but it's just spending an hour with one of my patients and I wasn't there, and eventually having some laxity. So what is the traumatic process of performing that exam? And I can see why. Well, okay, so if the animal is sedated, then they're not going to struggle. We're going to, look at this. So all that doesn't need to happen. You could have a relaxed animal and gently kind of move things and see what's going on, but do that in the context of a full myofascial exam, because what else can cause pelvic limb lameness? Trigger points, myofascial pathology, nerve entrapment, other ligamentous diseases. It could be something in the back or pelvis. There could be another neurologic or peripheral nerve disease, central nerve system, and so again, this narrow tunnel that we have been primed to think about, like what is the quickest road to get them to surgery, in my mind, is because we're not taught about all the differentials typically, or encouraged to think about them. So yeah, do the drawer test, but do it well and do it in the context of looking for everything else that's there and how we can better serve our patients and know better what's going on.
Okay, great. Thank you. So then you mentioned some research that was showing that the cruciate ligament heals. I'm not familiar with that research. Would you mind taking us through some of that and maybe sharing those references with us? Because I would love to have a look at that.
Sure. And I just printed out 3 because, we can always, so I'd say for anybody, go to pubmed.gov. At least that's where I go. And there's a lot of open access papers. For one thing, just as we were talking about, look for, TPLO versus conservative care. That TPLO is the gold standard, and you won't find anything there. And so just to start out with, I'll just read the titles because you won't be able to read them. This one is new. This is 2024. So just before I go to the the cranial cruciate healing. This is short-term outcomes of cranial cruciate ligament rupture treated surgically with TPLO or non-surgically in small breed dogs weighing less than 10 kilograms. So this is what we're beginning to see because people are starting to venture forth. You can see in your clinic that dogs recover even without surgery. So now we're just starting to get more of this information published. And so seeing, essentially equivalent outcomes, maybe the thigh circumference is a little bit more in the near term with surgery, but they both end up doing well. So we need more studies about the bigger dogs, but still. Okay, so here, 2023, a lot came out in 2023. Well, because we're only just into halfway. Okay, so this is human. Healing of anterior cruciate ligament rupture on MRI and outcomes following non-surgical management with a bracing protocol. So this is the first one I had found, 2023. Evidence of ACL healing on MRI following ACL rupture treated with rehabilitation alone may be associated with better patient-reported outcomes, a secondary analysis from the Cranial trial. Ligament healing, this is, I think, International Journal of Sports Physical Therapy. Ligament healing after anterior cruciate ligament rupture, an important new patient pathway. And then, of course, what will promote the healing? Not just we looked at an MRI and, oh my, that cruciate was starting to heal. Imagine that. We were told there's no vasculature. We were told it will never heal. Ligaments don't heal, or they heal pretty slowly. I mean, the cruciate ligament actually has tiny little blood vessels, so there is a capacity to heal. And then you look at stem cell, platelet-rich plasma, frontiers in veterinary science, partial cranial cruciate ligament tears treated with stem cell and PRP combination therapy in 36 dogs, a retrospective study. So we look at, again, instead of cut to cure, protect to cure, and that extends to spinal cord injury, intervertebral disc disease as well. We have to shift the paradigm because there's just so much evidence, especially when this is not an emergency. We can give rehab a try.
Okay, so let's chat about some of the alternative patient pathways. How would we treat them alternatively? And for those that are watching, I know you guys are going to want to go check out those articles. So I will try and get a list together between myself and Narada and share that with you, and hopefully some of the links to the articles as well. And hopefully I'll write about it as well for you guys and summarize it all and send it to you also, just so that you know that will follow. Okay, so let's talk about some of the alternative treatment approaches. If we're not doing surgery, what are we doing? Because I think the primary argument has always been that if there's instability of the stifle, we have a problem. So we need to stabilize it somehow. If we're not stabilizing it surgically, what are we doing?
Okay, yeah. So and first, and back to TPLO, that doesn't intrinsically stabilize the stifle. So it's more of a mechanical or functional thing. And the untold story a lot of times is, okay, well, when it's not done right or when things go wrong, yeah, there's still instability and there's still arthritis. So that's a big misconception too, is that, I mean, I still hear, because I have it as questions in my exams, in my courses. Have you been told that if we don't rush to TPLO, that there's going to be, horrible arthritis? And so still people are being taught that. And there's no evidence that shows that a conservative approach like we're doing today will produce more arthritis, number one. Number two, there's oftentimes more arthritis after surgery. So it develops either way. And some people will respond to this question, yeah, I've been told it happens either way. And so that's a myth. And just one other thing, just in terms of when I've written articles on this, just finding papers by surgeons saying, if there's a medial buttress, that's an indication for TPLO. I mean, why? That's a stable limb. And And so TPLOs are still being done on limbs that are stable. And so of course, there's the opportunity for orthotics, so braces. Um, and so, yeah, I mean, I have papers we can link to on bracing. And then there's also the misinformation that is taught out there. Oh, no, braces won't work. They will cause all these problems. No, that is not true. That is the old way. So if instability in the acute, maybe full rupture or whatever, if that's a problem, then there are soft braces, there are custom hard braces, there are things we can do to just get them more stable in the near term as we promote proper and balanced muscle function and restoration of bulk and tone, as we're doing that with an integrative rehabilitation program. One of the things that we note, again, driven by the nervous system, is when we're assessing the neuromotor control, oftentimes it's the hamstrings that are not firing well for whatever reason. And I hypothesize that sometimes it's just because maybe the dogs aren't being exercised on various types of terrain, and being whatever it's called, they're not activating. And especially like the biceps femoris, one of the hamstrings, I mean, that is like nature's own soft brace, because it starts at the sacrotuberous ligament, comes around to the cranial part of the stifle with the crural fascia, attaches also to the patella, really comes around. I mean, as a brace would. And the hamstrings are agonists for the cruciate. So when we have strong and firing hamstrings, they are opposing that pull from the quads, and that will create more balance in the stifle and keep that tibia from translating forward. So what can we do with that? We can do acupuncture, we can do massage, we can do therapeutic exercise. With the algorithm kind of, okay, what's the problem? I would want to match the mechanism of the current injury state or disease profile with the mechanisms of healing. So do we have pain? Okay, what's analgesic? Of course, there's pharmaceuticals, of course, acupuncture, strong pain relief there, TENS, so electrotherapeutics, potentially shockwave, massage. So we can address pain. Is there edema or effusion in that region? We have laser therapy, also good for pain. So we have a number of things that we can do to help reduce the effusion in the joint, which itself, when we have pain in the stifle region or thereabout, that is going to inhibit proper muscle function. So just even by addressing pain and swelling, we might restore proper mechanics, because whatever the state of the cruciate is, instead of being self-generated where it's knocking out the muscle firing, then we can help repair weight bearing just by treating some of the tissue changes. Stretching, range of motion, and neuromotor patterning. So again, getting the nerves to fire correctly, and addressing where is the tissue in terms of its healing phase. Is there something that's acute? Is it chronic? How has it affected the rest of the body? So instead of just focusing in this region, then, like what breaks my heart is when animals come down soon after a TPLO or have already had a neurologic problem complicating the situation, or the pain or the lameness might have been coming more from, again, a peripheral nerve or a central nerve problem. So proper diagnosis is key. And I don't know, that just reminds me of this whole idea, oh, you better start saving for the opposite stifle, because that's going to go too. No, there's ways we can employ the same things in a preventive fashion. Let's look at where is there inflammation. One other thing in terms of treatment and prevention and detection is right where the bone saw comes in and they lift the soft tissues right here. Acupuncturists will know this as spleen 9. This is a confluence. This is the pes anserinus, which is where the tendons from the sartorius,
Mhm.
the gracilis, and the semitendinosus converge right there with three different nerves, the femoral obturator and tibial branch of the sciatic nerve. This is a huge area for afferent information to come to the brain, coming from the craniolateral, the caudal, and the medial pelvis. This is such an important area to protect and not to mess up, with a bone saw coming near it, because the more we can, again, create a connection or restore the connection between the periphery and the central nervous system, the better our endogenous healing pathways are going to be able to restore that function before we mess it up with, once you cut, you can't go back.
Yeah. That has made me think of two things. We've recently had a webinar series with Dr. Elizabeth Uhl and Michelle Osborne, which was absolutely phenomenal. If you guys are equine members, do go watch that. But they spoke about a lot about the anatomy and about systems of redundancy built into the body. And what they meant by that is that the body has such a capacity for adaptation and for compensation that when there are anatomical variations or injuries, the body will adapt to compensate. So other structures can take over the function of that initial structure. And as you were talking about the crural fascia, that's exactly what was coming to mind, is that, that crural fascia is actually, it's massive, and it has a lot of a lot of muscles are attaching through there and functioning through there. And if we can get that to function as a stabilizing unit, which it would already be doing, but we'd have some neurological, some arthrogenic muscle inhibition potentially, that we can absolutely correct and change and work with. So that was the one thing that came to mind that I thought worth mentioning. And then the other thing, as you were speaking, is a vet that I work quite often with will say to me every time that she goes to surgery, a chance to cut is a chance to cure. And I think that is a very strong belief and mindset that they have, that isn't, something that I necessarily share, but that we should be aware of when we're working with veterinarians, especially surgeons, because if that is their belief system, how do we work with that and around that? So it's just some thoughts from my side. And then Ansi, it's so cool to have you. Hi. So Ansi says the current data suggests that 1 in 3 CCLs in human will heal conservatively. Difficulty is knowing if we can translate this data to dogs, bearing in mind the different angulation and mechanics. So that's quite interesting, 1 in 3. And I believe that surgery has also been the gold standard in humans for ACLs, although I don't know. Thank you for sharing that, Ansi. And then Heather, it's great to have you. Thanks for joining us. She asks, what are your thoughts on NSAID use for CCL treatment?
I mean, I think it's fine. I know that there's the idea that, will it inhibit healing, and that inflammation is pro-inflammatory. I mean, it's like, well, do we want inflammation? Do we not want inflammation? I think it's important to control the pain. Primary, before we start a rehab program, let's control the pain, and then the animal can bear weight more, and then we can, do what we need to do, and supplement with anti-inflammatory approaches, PEMF, pulse electromagnetic field therapy, laser, acupuncture, massage, all those things, and have it be multimodal. So if an NSAID is going to be good in the near term or for various flare-ups, then I think that's fine.
I love that. I think it's really great to remember that we have that multimodal opportunity. So when do we want to use each one? I love that. So guys, if you're watching this, if you're here with us live, it is so good to have you. We love chatting to you live. Please share any questions that you have. We are here to chat with you. If you're watching this as a recording, you're welcome to ask questions as well, and we'll come back and answer those. Okay, what have we not covered in terms of the cruciate? Because I think we've just actually flown through my my talking points, which I love. Yeah, was there anything else that we missed?
Yeah, well, I think that again, getting back to the people that call me in desperation for support of their not wanting to rush into surgery with their animal, that just as with some other approaches like the anti-nerve growth factor stuff, so that's another kind of thing, but like clients aren't being given the full picture. They probably don't understand the extent to which a TPLO, is reshaping their animal's leg. You're cutting, you're modifying. I mean, bone surgery, like it's so over the top, this whole TPLO thing, number one. But so what does the surgery actually involve? What's the complication rate? Like, how often do they hear about the amount of hemorrhage that can happen, the fact that hardware can come loose, the severe infections, severe resistant infections that can occur that will require like an explant. So, I mean, I've had colleagues with dogs whose TPLO got infected, the plate. I mean, it's extensive amount of cost and trauma to everybody involved. And then ultimately removing the plate, which the plate itself and possibly the metal ions that come out, you know, produces a 40 times greater risk of osteosarcoma. Which client, even here in Colorado, how many clients have been told before they subject their animal to a TPLO that the risk of cancer is increasing 40 times for that bone cancer? Again, there's just so many things that can go wrong, and who pays for it? The client. And who makes the money? I'm again not supposed to talk about all this, but it still benefits the veterinary practice, even if there's complications. So, and I just think, in general, we have to acknowledge the evidence and be willing to, counter like the dogma that does not have evidence. I mean, even when I've been speaking at lectures, and as well, what kind of double-blind studies? Like, what kind of double-blind studies do you have as a surgeon? You have no double-blind studies, but yes, we have mechanisms of action. We don't go woo-woo. We talk about, activation of endogenous stem cells with acupuncture and laser therapy. The ability of, tissue regrowth with photomedicine. So why are we apologizing or afraid to counter this notion of a chance to cut is a chance to cure? That is old news. This is we protect to cure, we don't cut to cure. And I think that, to me, the rehab profession, let's realize this is the way of the future. And you see in the human medical, even with these advances in understanding that the cruciate ligament can heal, even the orthopedists who have written about this, one guy said, it's professional suicide for me to say that you shouldn't rush into an ACL surgery, as a human. There are so many layers of pressure against what we're trying to do, what we who believe that try a non-surgical approach first if the client is interested. And, there's nothing wrong with that. Anyway, where were we?
Yeah. I definitely do believe that a client should be listened to. There are so many who are not willing to go to surgery, and they're just not given an alternative option.
Right.
And they do need to be heard and supported. So Heather, great question. Orthotics, is there any research of their ability to provide draw stability and rotational force stability?
Those specific outcomes, I'm not sure. I'd have to look at the studies, but just in terms of a beneficial outcome, and at the end of a year, like how are the animals doing? That clients are very satisfied with orthotics. And I mean, I think to drill down into those specifics, I don't know that the research is that specific, but again, I'd have to look at that. But you know, even after surgery, there is still a drawer. Let's say they've actually ruptured, you do surgery, there's still a positive drawer. I mean, until they're like so stuck or they're so edematous after surgery that yeah, that leg moves like a stick. And that's what I would notice when I was at the institution that I taught for 20 years. That I'd look at, because I'd run the pain center, and it's like I'm looking at that animal and there is less weight bearing, there is not normal movement or range of motion, and there are definitely a lot of things to treat, and there's kyphosis in the back, and the surgeon's like, wow, that dog is doing great. And you see, even on force plate studies, they're like, oh, normal force plate, striking of forces. Force plate analysis, especially for multi-limb conditions, I mean, that we try to study with that with herbs. It's like you can't even interpret that. Like, how are they weight shifting? If you had a healthy beagle and you cut the cruciate and you watch them before and after, yeah, that's a different story. That, to me, that's not ethical. But when you have actual animals, especially advanced age animals who are already struggling and have multiple areas of osteoarthritis, like, how are you going to really assess that? Because force plate is not an adequate measure.
It doesn't give you the whole picture. It's just one part of the picture.
It's just super hard to analyze, like, why? Because we're always weight shifting, and what else is going on? And how much back pain does that animal have? Or how, like, it's not like, I just think you have to see the entire individual, and with so many of the studies that are pro surgery, especially TPLO, they are written by surgeons. And so the more that rehab becomes its own field, is board certified in the US, and all that we do our own studies and show the value. Just this last week we were running our rehab course internship, and we have a Great Dane who had a TPLO, developed horrible infection, had to get it out, and by the time they did surgery again, the ligament was not completely ruptured. Maybe it was partially ruptured, but we don't know years and years before, 8 years before or whatever, what was the status of it then. So like, the amount of pain and suffering and money that went into this animal, and there was still some cruciate ligament there. What could we have done without doing that surgery and all that extensive resistant infection and ongoing problems today?
Okay. Heather, yeah, with the specific outcomes that you're asking for there, I'm not sure, but there are some studies, some preliminary studies looking at orthotics. So we'll find them and share them as well. And as far as I know, they've all shown positive outcomes, the orthotic studies with CCL, whatever they've measured. So whether that's increasing weight bearing or I'm not sure. I have to go look at them because I can't remember, but I have seen them. Do you know what they're called, Nada? Do you have them at hand?
Well, I have one. A study, prospective evaluation of complications associated with orthosis and prosthesis use in canine patients. So that was just one I pulled. But yeah, I mean, here, even written by at least one of them is a surgeon that I know. Yeah, I mean, let's look at the complications, but this is, let me see when it was. So 2022, with the diversity of orthoses that are out there now, and the ability to, either customize or modify, like this is not the old orthotic kind of thing. There's a lot that we can still do, but we shouldn't have to rely on bracing, because we can strengthen the tissue. We can, with therapeutic exercise, get those hamstrings firing, normalize movement and improve communication between agonists and antagonists, reduce hyper, pulling forward with the quads. So, so again, it's just this tide of, oh no, don't do that. Oh no, don't do that. Don't do that. Don't do that. Just straight to surgery. So I think the more that we talk about the science and evidence and options that there are. Again, why are we rushing in? Why are we telling them save money for the next one? Why aren't we having a preventive approach?
I love that. Thank you. So what do you offer your students at CuraCore, and a little bit, specifically around the subject, what can they expect and what do you cover?
Yeah, well, pretty much every subject that we teach would apply to this. So specifically the rehab course, but we do, have certification in medical acupuncture. It's been over 25 years, and massage and photo medicine and herbs. I mean, cannabis and this, that, and the other. But the integrative rehab and physical medicine course that we call MOVE, it's the internship we just did. I and my co-faculty, we talk about the basic science of, muscle function, of joint integrity, of the mechanisms of action of, laser exercise, all these things. And then compare and contrast treatment approaches. So each one of those and how they work and what they bring to the healing equation. And then we have a full, closely supervised 5-day internship where we bring animals from the community. So actual patients that they've done the online modules. So this is the only on-site piece they need to do. And the unique to our program is they get hands-on supervised. They are the veterinary, they are the practitioner working with the animal. And we have, very small groups with expert teachers working with them, and you develop a rehab problem list, a veterinary problem list. You have an initial evaluation. So the myofascial, looking at them from myofascial perspective, the how to see a dog, as I have named it, like watching them walk, so movement and function, and determining not only what the chief complaint was, but what are the contributing other factors and what's the main driver of the condition that we should focus on initially, but what's the client's understanding of things? What can the client do? How can we introduce therapeutic exercise for that client at home, but also this multimodal treatment paradigm that also includes active movement and, assessing, is that exercise accomplishing what we want it to? So we teach this assessment of the neuromotor patterning. So don't just put them through a predetermined protocol. Let's tailor it to the individual. And then for many of the dogs, we see them a second time that week, because what I've seen with rehab courses or when they graduate, like people are often lost, like, where do I begin? Because there are so many modalities. So we have them see them again and, practice that assessment. Does something need to change? What's the vision for the short-term goals and getting the client involved? And what are the long-term goals? And so you really get, real life experience. Cerebellar hypoplasia, the stifle conditions, intervertebral disc disease, elbow arthritis. I mean, just really get the ability to perform your rehab skills that you're new at, and then, put them into play with a patient. And then we just follow people up. We have thousands of graduates in from all our programs, that we have a community that we can chat on Facebook and elsewhere.
Awesome. Okay, so CuraCore Vet, guys, if you want to learn more. Heather, you're asking fantastic questions today. I'm going to ask yours in a second. Suzanne says, I think a lot of this is also due to not enough knowledge in vets. Me being one myself, all I was ever taught is that surgery is the only way to cure the stifle. So educate us for other options. Thank you, Suzanne.
Yeah,
I really appreciate that. Yeah, it is difficult, and I mean, we understand that is what you learn as veterinarians, and it is our mission to work with you always. Without the team approach, our hands are 100% tied. There's very little that we can do if we're not working within that team. So thank you, I appreciate that. And then Heather says, so what exercises are you finding is helping the majority? So if you're, using therapeutic exercises, where are you focusing? Which exercises are you finding effective?
Well, good question, as are all your others. So we have to figure out, well, where is the individual currently? So, and that's where, what can they do? Well, even to back up, what's going on with them, and not just narrowly on the stifle, but is this a 4-limb amputee as well, or anything else? So in the big context, but for a stifle issue, so do they have pain? Is it acute? And is it the cruciate? But so often, as I had mentioned, it is an issue with the hamstrings not firing well enough. So a little bit of an elevated stand. I mean, you can start really easily, and if you're doing a mobile practice and visiting, so you could have well, either a foam pad or something, some pillows, so just something stable to begin with to shift the weight back on the limb. And they need to regain their confidence that they can put their limb down. And sometimes that will involve like just some massage to start out with, and just some treatment, maybe to take down some pain, whatever, in the beginning. And then have them bear weight fully, and then you could do a little bit of weight shifting side to side. So these aren't big extravagant things, especially in the beginning. We're not going to do a sit to stand and all these built up kind of things. We want to start slowly, and then we can think, do we want to use concentric exercises, isometric exercises, eccentric exercise, and know how to progress forward as that animal does that? How are we going to challenge them more, either with elevation or with some instability, and then talk to the client about, if there is actually a cruciate injury and it's acute, not to confine them for weeks and weeks. Let's get them weight bearing. Let's keep that joint healthy, and don't let them just, like, they're looking better. Okay, so just don't let them in the backyard and chase a squirrel, because that's not going to be good. So really being careful in that initial healing time, and not overdoing it, and then gradually increasing the challenges towards an eccentric type of exercise, towards just more challenging, more strength. But we're starting with goniometric measurements, girth measurements. Let's have some objective data there, and teach the client things to do at home. I mean, nowadays too, there are photomedicine devices. I mean, they're LEDs mostly, but under US $200, and they can add in some photomedicine to keep pain down, to keep inflammation down, to promote healing and cell division and all that stuff, right at home. So so there's a range of things to do, and but we want to make sure we're good with the basics and be monitoring them. So they're doing like an elevated stand. What do you want to accomplish? If the hamstrings were not firing, we're going to feel those muscles. And how do we need to modify the elevation or the conformation to make sure that these muscles are indeed firing and accomplishing what we want them to do?
Perfect. Thank you so much. All right, guys, thank you to everyone that's joined us live. It's been amazing having you, Nada. That was really interesting. Thank you. We're going to have more of these conversations, and really going into the tricky territory where we feel uncomfortable when we're talking about the ethical dilemmas that challenge us. This question of surgical versus non-surgical approaches is a difficult one, because it isn't our decision at the end of the day. And as Suzanne highlighted, it can really feel like we're going against our vets. We're not working together, and that's not our goal. We want to be working as a team, and that's why this feels difficult. But how can we bring a different perspective? How can we have these conversations, educate ourselves, educate the vets that we're working with, and offer our owners an alternative route that they might not have been aware of? I think that's all really important. And so, guys, please join us for the Vet Rehab Summit on the 31st of August, where we are going to deep dive into some of the ethical dilemmas that we face as vet rehabbers. It is going to be fun. It is going to be interesting. It's always a phenomenal event. So mark it off in your calendar and make sure that you guys join us live. Nada, thank you so much.
Thank you.
All right. Bye.
Bye.